Dear colleagues, I would very much like to thank you for your kind invitation to give this introductory remark to your wonderful conference, and I would like to congratulate you to organize a meeting about automated breast ultrasound. You know very well that it is our generation, the very first in thousands of years, that decided and also was capable to change the outcome of breast cancer patients significantly. And it's not because of chemotherapy, not because of adjuvant treatment, but because of early detection. We decided to get rid of the advanced cancers and operate with a new paradigm by finding cancer before the women can feel it. And the randomized controlled trials really proved that early detection, that is, treating years before it would be palpable, is going to decrease mortality significantly. But we have considerable problems, and one of them, the first to mention, is the heterogeneity of the normal mammograms. We have classified 27,000 women, asymptomatic screening case, and compared the mammograms with large section histology. And we created these 5 mammographic parenchymal patterns. Of these 5, 3, that is, about 40 to 50% of all screening women in an asymptomatic healthy population had so-called dense breast. These are the cases where we have considerable limitation in finding breast cancer in the desired 1 to 14 millimeter size. And we have to compensate for that. Now, the development of tomosynthesis is not going to solve the problem we call dense breast. It certainly provides nicer mammograms, and it can be used and should be used in working up cases. But for screening asymptomatic women, we need ultrasound. Right in front of you, there is a woman with a 2.5 centimeter carcinoma, which is node positive, and none of us know which breast are we talking about. It is going to be this one. You see immediately the limitation of mammography and the capability of ultrasound. But handheld ultrasound cannot be used in a large-scale screening of asymptomatic women. It is operator dependent. It has poor standardization. So there is a tremendous and urgent need for developing automated breast ultrasound in addition to full-field digital mammography, not replacing it. The technique is simple, and the current Innovenia machine is used very successfully. It's automated because the 14 centimeter probe is running automatically over the compressed breast tissue and generates these 2 millimeter thick slices. Slice after slice, we are going to see these, I should say, ultrasound CT pictures. And as soon as there is a tissue defect represented by accumulation of fluid, that is cysts, or cancer, we are going to find them very easily. You can imagine we just missed the mammogram. You can imagine we just missed the cancer on the mammogram. Now you are going to see it several times. It is revolutionary, and I would really suggest a new name, ultrasound CT, for that. But in order to learn the automated breast ultrasound images, you have to do exactly what we are doing in mammography, namely learn the three-dimensional histology image of the terminal ductal lobular units and the ducts and its branches. And then you are going to see very nice comparison with plants and trees. Dear colleagues, this is how we teach young radiologists to read a mammogram. We are going to ask the question, what is this linear density here? And we correlate it with the three-dimensional histology image. Likewise, what are these nodular densities? They correspond to the milk factory, the terminal ductal lobular units. We wrote books about this. Here is one of the books where you can look through the stereoscopic glasses and see these stereo images as three-dimensional images. I'm very happy to mention to you that our first three-dimensional book is on the printing in Chinese, and we plan to print all 10 books of ours translated to Chinese language. So you see, that was the mammogram. But now you can compare the automated breast ultrasound equally well with the three-dimensional histology image. Here are the large number of terminal ductal lobular units as nodular densities, and here is a duct. Here's a Cooper's ligament, which is actually fibrosis, ducts, as well as terminal ductal lobular units, which are very nicely seen on the automated breast ultrasound image. When there is a fluid accumulation and there is a carcinoma growing, we can see this as a tissue defect, and we decide that this is going to be a case for callback and further assessment of the finding. Actually, this large section histology image very nicely presents the problem we have, the so-called iceberg phenomenon. You see that in this dense fibrosis, most of the cancer is hidden. Only the tip of the iceberg can be seen. And the ultrasound beam acts as a radar, and it points out for us, just like the handheld ultrasound, just like the MR image, while the mammogram missed it. Our big problem is the architectural distortion. Many times we miss an 8-centimeter diffusely invasive carcinoma. This is the method, the three-dimensional automated breast ultrasound, that is brilliantly demonstrates the presence of architectural distortion. We hope that these huge carcinomas that unfortunately lead to breast cancer death all too often are going to be found much earlier when using ABUS. So, in summary, when we work up the cases, we want to arrive at the correct diagnosis. We use workup mammography, handheld ultrasound, interventional methods, MRI, but when it comes to screening, we should use the 3D automated breast ultrasound. That is, screening should not only be done by fulfilled digital mammography, but also with added automated breast ultrasound. And we have carried out a very large-scale trial on 15,000 women. The designer was Prof. Steve Duffy. All women out of the 15,000 had more than 50% density. And it showed, as it's published in Radiology, that about 30% more invasive carcinomas we find. This study provided information, what we badly needed, namely the combination of digital mammography and automated breast ultrasound is a very new and desired multi-modality tool in the fight against breast cancer. Quite recently, an EASY study from Europe has been published, and this is invaluable because it proved that the callback rate did not increase significantly. And again, also the study found significantly higher rate of invasive breast cancers. Dear colleagues, when concerning the future, we need to think about CAD added to ABUS. Here is the current image, and here's the CAD. It sees through all the layers of the slices, and it's going to help the physicians to find cancers very easily in a very short period of time, and they can call back the patients with tiny carcinomas. These are the thoughts I wanted to share with you, and I would very much like to congratulate you for organizing the meeting, and I would very much like to, and I wish you all the best with your conference. Thank you very much.